Thank you, everyone, for joining the NF Network webinar series. I'm Kim Bischoff, the Executive Director of the Neurofibromatosis Network, and we'd like to welcome you. Today, we have registered 341 people to be a part of this very exciting presentation that we will hear this evening. We are very fortunate to have Dr. Thomas Wilson, who attended the University of Nebraska College of Medicine, earning his MD with highest distinction. He is now Clinical Assistant Professor and Co-Director of the Center for Peripheral Nerve Surgery at Stanford University. Tonight, Dr. Wilson will review the types of benign nerve sheath tumors, including the most common tumors involved in neurofibromatosis, namely Schwannomas and Neurofibromas. Dr. Wilson will review how these tumors grow and the differences between the two types of tumors. We'll try to answer two major questions. When should you consider removal of a tumor, and what are the risks associated with the tumor removal? Finally, Dr. Wilson will discuss warning signs and when you should be worried about your tumor. All of this will be done from a surgeon's perspective, with the focus on special challenges that are present in making decisions with patients who have multiple tumors. Ultimately, the goal is for you to have a better understanding of neurofibromatosis, when to be worried, and the surgical options available for treatments of NF tumors. Dr. Wilson is going to do his presentation tonight, and we'll save about 10 minutes for questions at the end. So there is a box in your dialog box there that says questions. If you would put your questions in there, at the end I will read them to him. So without any more delay, I would like to introduce you to Dr. Thomas Wilson. Thank you for joining us, Dr. Wilson, and for giving up your evening this evening for us. We really appreciate it.
Thank you for having me. It's certainly an honor to give a presentation to a really important group and a really, really tough disease. So I'm going to, as you sort of alluded to, I'm going to take a surgeon's approach to the talk tonight and just give, I'm going to start with some sort of low-level overview, and then we're going to kind of get into the tumors that face people with that have to do with nerve tumors that you think that I can help answer, please feel free to send me an email, or we have a peripheral nerve surgery website. This is the address to that, and there's more information about nerve tumors and nerve surgery in general on that if you're interested. So the outline for the talk tonight, I'm going to try to tackle a variety of questions. I'm going to start with what are the types of nerve tumors in general? And then more specifically, what are the types of nerve tumors that we see for people that have neurofibromatosis? And I'm going to include under that heading schwannomatosis as well. So we'll talk a little bit about that in addition. I'm going to then switch gears and talk about how nerve tumors grow. This is important in understanding the risks that go along with taking a nerve tumor out and why the risks might be different between the varying kinds of nerve tumors. I'm then going to talk about when should you consider resection of a given tumor. And as part of this, it's always important to consider what are the risks that are associated with the surgery. I'm then going to delve into the details a little bit about how these tumor resections are actually performed. And I'll try to give you a little bit of a warning when I get to this part. There are some surgical photos that are in this part of the talk. And so if people are a little bit squeamish, a little bit shy about seeing blood and those kind of things, I'll give you a little bit of a warning when I get to that part. You might want to look away for a couple of minutes and just listen to what I'm saying. And then finally, which I think might be the most important part of the talk, is when should I be worried about my tumor? I'm going to go over some of the warning signs so that if any of these crop up, you can be appropriately concerned and get a prompt evaluation. So to start with, we'll talk a little bit about what the types of nerve tumors are. So the main types of nerve tumors that we think about are far and away schwannomas and neurofibromas. But it turns out there's actually a variety of other kinds of nerve tumors. There are tumors called perineuriomas. There are cysts that form in nerves that some people refer to as tumors. At the end of the day, there's a wide variety of types of nerve tumors. But when we think about the types of nerve tumors that are really specific to neurofibromatosis, it's schwannomas and neurofibromas. There is actually an entity that is a combination of the two of those. Those are referred to as hybrid tumors, and they are part neurofibroma and part schwannoma. So you may, if you're trying to read about these tumor types, may come across that designation. But the things that I'm going to say about neurofibromas and about schwannomas apply to these hybrid tumors as well. Now, when we think about the groupings of tumors, schwannomas, neurofibromas, and these hybrid tumors are all benign. We talk about these as being tumors, but they are not cancer. And then we always have to think about the cancerous counterpart to that, which are what are called malignant peripheral nerve sheath tumors, or you'll see this abbreviated MPNST. So we'll talk about what the risks are with these various kind of tumors and what the risk is of them converting to their malignant counterparts and what some of those warning signs might be. So in order to better understand the differences between schwannomas and neurofibromas, we actually have to take a step back and understand a little bit about the structure of a nerve at a more microscopic level. So I think many people think about nerves as being a solid structure, but in reality, they're much more like an electrical wire, if you've ever seen the inside of an electrical wire. So at a very basic level, there are individual wires, and these individual wires are called axons. Each axon is then wrapped with a covering, and that covering is what is called myelin. This covering forms basically the insulation for these individual axons, the individual wires. The axons are then bundled together into what we call fascicles, and then the fascicles are bundled together into what we call a nerve. So when we think about the two main types of benign nerve tumors, schwannomas and neurofibromas, they actually grow very differently from each other. So schwannomas form from this myelin sheath. That's why these are called nerve sheath tumors. They form from the sheath of the axon. And when the schwannoma forms, it grows typically originating from one axon, which is inside of one fascicle. And I'll come back to why that turns out to be important when we're thinking about removal. In contrast, neurofibromas, the origin of those is actually much less clear. They tend to involve the myelin sheath, but they also involve some of the connective tissue that is between the fascicles and between the axons, so that when neurofibromas grow, they oftentimes are growing in between the axons, in between the fascicles, and this has relevance for when we think about removing these tumors. So when we look at a nerve in cross-section that's containing one of these tumors, what a schwannoma typically looks like is it has one fascicle of the nerve coming in. That fascicle has the tumor on it, and one fascicle coming out the other side of the tumor. And all of the rest of the fascicles or bundles that are within the nerve are actually not part of the tumor. They are pushed out of the way as the tumor grows. Sometimes they're pushed out of the way as a bundle, like is depicted here in the picture. Sometimes they're pushed out of the way where they are more spread out. Say one bundle might be here, one bundle might be here, but they are not part of the tumor. And that's the important thing to understand. Whereas neurofibromas, because they tend to grow in between the bundles, they oftentimes involve a lot more of the nerve. So you can see there is one fascicle here, there's one fascicle here, there's one fascicle here, and those are all involved as part of the tumor. So you can imagine that if I were going to go in and try to take out a schwannoma, I could take out this tumor and the one fascicle that the tumor is involving, and I could leave the majority of the nerve behind and working. Whereas with a neurofibroma, that turns out to be more difficult. There are more fascicles that are involved in the tumor, and so removal of the tumor oftentimes involves removing more of the nerve. And so the risk profile that goes along with neurofibromas is going to turn out to be different than schwannomas. Now, there is a form of neurofibroma that is referred to as a plexiform neurofibroma. What that really means in sort of simple form is it is a whole bunch of individual neurofibromas that are in very close proximity to each other. And so rather than being one discrete mass, they oftentimes look like a sheet of a tumor. But in reality, this is a whole bunch of individual tumors, you know, say one here and one here and one here, that are all growing very, very closely to one another. But you can imagine that trying to take out a plexiform neurofibroma, basically the entire nerve is involved in the tumor. And so taking out a plexiform neurofibroma usually means that you're taking out the nerve with it. So we'll come back to why that's important. So now looking at this a little bit differently, if you think about looking at a tumor kind of in cross section, so now we're looking at a tumor relative to the nerve. This shows again how schwannomas basically grow next to most of the nerve. There is one fascicle that is inside the tumor, but the majority of the nerve is actually not part of the tumor. So you can separate this away and take the tumor out, leaving the nerve behind. Neurofibromas, on the other hand, this does a good job of depicting that the whole nerve is kind of coming in and is in the center of this tumor. So it's much more difficult to take this out and leave the nerve behind and functioning. So as we think about this, it's important to think about, well, what kinds of nerve tumors are we talking about in each of the individual conditions? So in neurofibromatosis type 1, when we are thinking about nerve tumors, the majority of those nerve tumors are neurofibromas. And specifically, neurofibromatosis type 1 has a predilection for forming the plexiform type of neurofibromas. In fact, one of the diagnostic criteria for neurofibromatosis type 1 is the presence of a plexiform neurofibroma. And these neurofibromas have the risk of converting into a malignant tumor, what's called a malignant peripheral nerve sheath tumor. In contrast, when we're thinking about neurofibromatosis type 2, those are typically schwannomas. The nerve tumors in that condition are schwannomas rather than neurofibromas. And the risk of converting to a malignancy is actually much, much lower in neurofibromatosis type 2 than it is in type 1. Similarly, in schwannomatosis, the typical tumors are schwannomas. Now, in any of these three types, you can have the hybrid form of those tumors, where they are part neurofibroma and part schwannoma. But in general, we think about schwannomas going along with NF2 or schwannomatosis, and neurofibromas going along with NF1. So if there is a nerve tumor, when should we ever think about removing a nerve tumor? So I'm going to start by talking in generalities. And what I mean by that is, this is my list of reasons why you might think about removing a nerve tumor for people that do not have neurofibromatosis or schwannomatosis. So let's imagine a person has a single tumor. Why might they think about removing that tumor? So in my mind, there really are 5 reasons why you might think about removing that tumor. So the first, and probably the most common, is that the tumor is symptomatic. It is causing a problem in some way. So the most common reason, or the most common symptom that people might get related to their tumor, is pain. But real estate is everything when it comes to tumors. So the location is really, really important. So for example, a nerve tumor that is growing inside the skull, inside the head, near the brain, might grow to the point that it's actually pushing on the nearby brain or brain stem. pressure on your brainstem. Similarly, some of these tumors grow along the spinal column next to the spinal cord. In those circumstances, these tumors can grow large enough that they are actually pushing on the nearby spinal cord, and there can be symptoms from that. When we're thinking about tumors, though, that are in the extremities, so in the arm or in the leg, far and away the most common symptom that will go with these tumors is pain. So overall, the first reason to think about removing these tumors is if they become symptomatic. The second reason to think about resection would be if the tumor is growing. As tumors get bigger, they generally become more difficult to remove, and the removal then becomes associated with a higher risk of creating a new problem by taking the tumor out. So most people have sort of varying thresholds where they will say that the tumor certainly becomes more difficult. I think that tumors become somewhat more difficult when they are bigger than 3 centimeters, and they definitely become more difficult when they are bigger than 5 centimeters. If a tumor is growing, that might be a reason to think about considering removal while the tumor is smaller and easier to remove. The third reason would be if there is any concern that this might not be a benign tumor, that this might in fact be a cancer or a malignancy. In those circumstances, there might be a need for getting tissue to actually make a diagnosis, or that might be a reason to consider removal if we are worried that this might not be a benign tumor. The fourth reason is to reduce or eliminate the need for follow-up. Typically, once a benign tumor is removed, the risk of a recurrence is exceedingly low. And so for most people, they can have the tumor removed and just kind of put this behind them. They don't need to have additional scans. They don't need to have additional follow-up. Once their tumor is gone, it's gone. And the fifth reason is that some people are very psychologically fixated on their tumor. It's very debilitating to them. They think a lot about having a tumor. They're kind of constantly worried about the fact that they have a tumor. And in some ways, it's the psychological part of having a tumor that is more debilitating than anything. So if we take that as the list of reasons why you might consider resecting a tumor for everyone, meaning people that don't have neurofibromatosis, which of these conditions might apply to people that have neurofibromatosis? Well, I think that 2 of these go off the list. So unfortunately, people that have neurofibromatosis or schwannomatosis typically have multiple tumors. And in most cases, all of the tumors can't be removed. So the psychological issues that surround the presence of a tumor, removing a single tumor doesn't really change that. And similarly, removing a single tumor amongst many tumors doesn't really change the need for additional follow-up. So if we remove those from the list, then I think for people that have multiple tumors, people that have neurofibromatosis or schwannomatosis, there really are 3 reasons why you might consider resection. And that is symptomatic tumors, growing tumors, or if there is a concern for malignancy. So when we think about should I have a resection of the tumor, there always has to be sort of opposite sides of a scale. So on the one side, there is, well, what are the benefits that I might gain from having my tumor removed? And on the flip side, that is always being weighed against, well, what are the risks of having surgery? So there are a variety of things that are important to consider if we're considering that kind of risk profile. So the first thing is the nerve involved. So some nerves in our body are vitally important for movement. Some nerves control very unimportant movements, and some nerves don't have any movement at all that's associated with those nerves. They are sensory nerves. And so it's a way basically of thinking about what is the risk associated with removing a tumor is, let's imagine the worst case scenario. Let's imagine that that nerve that the tumor is in got cut in half. What would the risk or what would happen if I lost that nerve altogether? that gives you a sense of kind of what is the worst case scenario that could happen if I lost this nerve. And in some nerves, that means that the deficits or the resulting problems would actually be quite minimal. You could afford to lose that nerve and not really have many issues. Whereas for some nerves, that would result in quite serious problems. And so understanding what the nerve does that is involving the tumor is really important. The second thing would be, well, what is nearby? Anytime we're going in to try to take out a tumor, we're working next to whatever is surrounding that tumor. So that might be blood vessels, that might be muscles that are nearby, but in some circumstances, it's really important things like the spinal cord or the brainstem. And so if there are really important things that are right next to these tumors, that increases the risk that is associated with removing the tumor, because there is always at least a small risk that the surrounding structures would be damaged by trying to take out the tumor. Size is another important consideration. The size of the tumor, as I mentioned, as it gets bigger, these tumors become harder to remove. And so smaller tumors have lower risk than bigger tumors do. The next important feature is accessibility. And what I mean by this is, can I expose the entire tumor and even the normal nerve on both sides of the tumor easily? So some locations of the body, this is very easy to do. If you have a tumor in your forearm, that usually means that I'm going to be able to expose and see the entire tumor and the normal nerve that that tumor is in on both sides of the tumor. Whereas you can imagine if you have a tumor that is way down deep in the pelvis, or if you have a tumor that is hidden behind your clavicle, your collarbone, for example, these are going to be places that are just much harder for a surgeon to access and reliably visualize the entirety of the tumor. So as the accessibility gets harder or lower, the risk associated with taking out a tumor goes up. The next thing is a primary resection, and what I mean by that is the first try at resecting a tumor or removing a tumor versus a redo. So I'll, in a little bit, talk about what the technique is for removing these tumors. But what happens when you try to remove a tumor is that you develop a little bit of scar tissue related to that. And scarring is the enemy of a good resection or an easy resection. And so anytime you are going back in a second time trying to remove a tumor, it is much harder to do than the first time around. So a redo resection has more risk than an initial or primary resection does. And that is actually similar to the idea of a biopsy. So for people who have had a biopsy with a needle to try to get a diagnosis, the resection is more difficult. And the reason for that is that the biopsy creates scarring. And when there is scarring present from a biopsy, the resection of the tumor becomes much more difficult and has a higher risk. And so later in the talk, I'll also talk a little bit about this. When do we use biopsies? We have to be cautious and judicious about when we use biopsies, because if we are then going to ultimately go in and try to remove this tumor, the tumor is harder to remove if you've had a biopsy. The last thing is that the tumor type affects the risk profile. So because of the way neurofibromas grow, as I pointed out, they tend to involve more of the nerve. They are less easy to separate from the remainder of the nerve that is not part of the tumor. Whereas schwannomas typically are very well encapsulated. They involve one fascicle of the nerve, and they can separate easier than neurofibromas can. And so if we compare the risk profile of those two, neurofibromas have a higher risk than schwannomas do. So as we think about the various types of neurofibromatosis, the risk profile is a little higher if I'm taking out a tumor in somebody with neurofibromatosis type 1 because they have neurofibromas than it is in people with neurofibromatosis type 2 or schwannomatosis because their tumors are typically schwannomas. So we always have to think about that when we're approaching discussions about what are the risks with tumor surgery. And then finally, this gets back at kind of what is the nerve involved. We generally think about nerves doing three things. So they can control motor function, movement. They control our sensation. That's the ability to sense touch, to sense temperature. And then finally, they also are what mediate pain. So if we do a nerve surgery or a tumor surgery in a nerve, you can have any of those three things be disrupted. So you can have resulting weakness, you can have numbness, you can create nerve pain, or the last thing is what we call paresthesias. That's really tingling. So you can imagine, as I described the way that nerve tumors grow, in order to remove a nerve tumor, you have to open up the nerve and try to separate away the uninvolved parts of the nerve and then pop the tumor out. And that is easier said than done. Nerves weren't built to be opened up. And so when you open up a nerve like that, it can be very irritating to the nerve. It can cause tingling, it can cause pain, it can cause numbness, and if you resect or injure the other parts of the nerve, you can also end up with weakness as a result of that. So, well, how realistic is that? Meaning, how likely are you to get a problem after having a tumor removed? And then, as we said, on the flip side, what's the likelihood that I'm actually going to benefit from having one of these tumors removed? So there have been some studies on this topic. This is one of the more recent ones that was published in one of our academic journals. And this looked at a big experience of one surgeon, over 400 of these tumors. Now, this is for all comers. This is not for just people that have neurofibromatosis or schwannomatosis. This is for all benign nerve tumors. And they really looked at what are the outcomes? How likely are we to cause problems? How likely are we to actually result in a benefit? And what this author found is that in cases that he did, there was about a 6% rate of new weakness after the operation. Now, fortunately, the majority of those progressively improved over time. So 75% of those recovered by 1 year. But that still means that there is about a 1.5 or 2% rate in this series of permanent new weakness after having one of these tumors removed. So that's an important consideration when you're thinking about the risks. Now, on the flip side of that, if somebody came into the operation having weakness, what this author found was that about 80% of those people improved their weakness after surgery. So an 80% chance of improvement if weakness is there versus a 2% chance of new weakness that is permanent after the operation. So you have to think about those odds. Now, in addition to weakness, I mentioned you can also develop pain or very bothersome tingling after the operation. This author found a rate of 17% or nearly 18% of people had new nerve pain after the operation. Now, they don't comment very much about how lasting that nerve pain was, but that's a pretty high rate. 18% rate of new nerve pain after having one of these tumors removed is pretty significant. That's almost 1 in 5 people having new nerve pain. So these are not trivial tumors to remove. They can certainly cause new problems. Well, we have looked at that here at Stanford, and we have combined our data with 5 other major academic centers around the country. And this is what we have found. So this data is not published yet. It probably will be published in the next year or so. So I'm giving you a behind the scenes look at kind of what our outcomes have been and a little preview of probably what is a publication to come. So what we found in the combination of these 6 centers that include Stanford is that our rate of new nerve pain after a tumor surgery was about 8%. And that includes everyone. So even temporary increases in nerve pain were about 8% after the surgery. Permanent increases in nerve pain were seen in about 4% of people. Now, the thing that we found to be the most common was bothersome paresthesias, so bothersome tingling after the surgery. 21% of people had bothersome tingling that was at least temporary after the surgery, and 13% of those, it was permanent. So this matches certainly what my experience is. I think actually the most common problem to have after removing one of these tumors is bothersome tingling. And that varies in severity, but this only includes those patients that would report it as at least being bothersome to them. So this is a significant number. At least 1 in 10 people have bothersome tingling after a tumor surgery. Motor deficits, so new weakness. This is usually what everybody's main concern is after having one of these tumors removed. We had a 7% rate of temporary or permanent worsening, and a 3% rate of permanent worsening. So permanent new weakness, 3%. Now, if you combine all of those together and ask, what is the chance that I have any new neurologic problem? So new pain, new weakness, new tingling, 27%, so 1 in 4. That's very, very common. So I point that out to say that these are not insignificant risks and not trivial tumors to remove. Now, fortunately, a good number of those recover, but you're still left with 12% of people who have permanent worsening of some form: pain, tingling, weakness. Now, this study basically was done for only people that have tumors outside of the head and outside of the spinal column. So tumors that are in the extremities, tumors that are in the pelvis, tumors that are in the neck. That's what this study included. So it actually excludes what would be the highest risk group of these kind of tumors to remove, which are those that are near the spinal cord or near the brainstem. Now, that's the risk profile that we have come up with. Now, on the flip side, what's the likelihood that you are to get a benefit having these kind of tumors removed? So we found that if somebody has pain as their main complaint, they have about an 84% chance of reporting improvement in their pain when their tumor is removed. So that's quite good odds. Similarly, if people have bothersome tingling as the symptom that they are presenting with, they have about a 70% chance of improvement. And that is pretty similar to that of weakness. So if weakness is the main symptom that they're presenting with, they have about a 70% chance of improving. So the odds of improving after having a tumor removed are actually quite good, 70 to 80%, depending on what the presenting symptom is. But that always has to be weighed against what is the risk that I'm actually going to worsen. And that's about 12%, with the most common worsening being tingling, and then about equal that you would have new pain or new weakness. So that then gets after, well, how do we approach these kind of tumors? What's the goal in the surgery? So the goal in these operations is to try to remove the tumor, but leave the nerve working. So in a very simple sense, that's what we want. We want tumor gone, nerve still behind, and the nerve to still be working when we're all said and done. So this is a simple drawing of what really the goal is. The goal is to take the tumor out and leave this nerve all connected, with only the little fascicle that is actually giving rise to this tumor being taken out with the tumor, and the whole rest of the nerve being left. So this is a drawing, but it actually turns out that, at least for schwannomas, this is a lot of what it looks like in the operating room. So the next several slides are going to be some pictures from the operating room. So this is where, if people are a little squeamish, don't like to see blood, or like to see what nerves actually look like, maybe look away for the next couple of minutes and just listen to what I'm saying, and I'll give you a heads up when I'm going back to the regular slides. So this is what these tumors actually look like in the operating room. So you can imagine how that drawing applies to what you're actually seeing. So here in the background, this is the nerve. This has been dissected in a way that you're down to the single fascicle that is then coming up into the tumor, and then coming out of the tumor is that single fascicle going back into the nerve. And so in an ideal world, this is exactly what it would look like. You would be able to cut this fascicle, you would cut this fascicle, and then the whole tumor would come out as one piece. And when that's all done, then you've left all of the rest of the nerve behind and working. So we use a combination of our eyes to just visually look at what the relationship is of the tumor to the rest of the nerve. But we also can use electrical stimulation in the operating room. This helps us map out where there is nerve and where there is just tumor. When we stimulate the nerve, we get a response. And typically, when we stimulate the tumor, this fascicle that is growing the tumor is usually dead. Basically, the tumor kills off this one fascicle of the tumor. And so when you stimulate the tumor, you don't see any response as a result of that. So we can use this electrical stimulation technique to kind of map out where is the tumor and where is the other part of the nerve. So kind of from start to finish, this is an example of a sural nerve tumor case. So this person came in and this is what their imaging looked like. So typically these tumors on an MRI are very bright, and they are tumors that I like to kind of refer to as being kind to their neighbors. And so what I mean by that is if you look at this imaging, you can draw a very distinct line around this tumor. The tumor is not projecting out into the nearby structure. So this is muscle, and there are not fingers of the tumor that are growing out into the muscle. It's not invading things that are around it. It's playing nice with its neighbors. That is usually a suggestion that it is a benign tumor. Cancers tend to kind of have very ragged, irregular borders. They tend to invade things that are around it. They don't play nice with their neighbors. So this tumor is what a typical benign tumor would look like. Now, if you looked at that on an ultrasound, you get a similar appearance where the ultrasound shows this dark tumor, and it is a very nice border. It's a smooth border. It's not invading out around everything else, and that's what's typical of a benign tumor. So this tumor was on the back of the leg. So this is the calf right here. This arrow is pointing to the knee crease just to kind of give you some orientation. And the tumor was right here. You could feel it through the skin. So when I made an incision, this is what that nerve tumor looked like before I started trying to separate it away from the nerve. So you can see, maybe if you use your imagination a little bit, this is one little line of the nerve. This is one little line of the nerve. And so the question is, where is that going relative to the tumor? So once we start to open this tumor up and open this nerve up, the goal is figure out where this nerve is going and figure out where the tumor is at. So once we do that, we can ultimately try to separate away all of the uninvolved nerve, which has been pushed aside, and we can get it down to that one little fascicle that is actually giving rise to the tumor. When we cut that fascicle, and then similarly on the other side, cut that fascicle, this whole tumor can then be lifted out as one piece. And then what's left behind is the uninvolved part of the nerve. So this is the part of the nerve that was kind of sliding by the tumor that I peeled away from the surface of the tumor in order to be able to remove it. So this is what that tumor looks like after it's removed. And once we do that, we send this off to the pathologist to look at under the microscope and to give us a diagnosis. And this turned out to be a schwannoma in this case. So I point that out to say that that's what the goal is. You know, the goal is to be able to sort of slide all of this away, but that's much easier said than done. but you can also, I think, appreciate what this nerve looks like at the end of a tumor operation. The tumor has been, the nerve has been opened up, it's been kind of slid around and manipulated, and the nerve just doesn't look happy. You know, even in sort of the cleanest of the cases, which this is a pretty good example of a really, really clean operation, you can see that I had to make an incision into the nerve and get inside it. And so that's why there is this risk of worsening pain, worsening tingling, or even weakness related to that, even when these operations go very well. So I think that tries to give kind of a visual representation of why there are risks associated with taking out these benign tumors. And those were schwannomas that I showed. That's actually even more difficult for neurofibromas. Okay, so now we're going to come to what I think is probably the most important part of this talk, and that is we've spent a lot of time thinking about benign tumors. Now, the follow-up question to that is, when should I be concerned? When should I be thinking, could my tumor be a malignancy, and I really need to get this promptly evaluated? So I'll go back to saying that risk is higher in people with neurofibromatosis type 1. That doesn't mean that people with NF2 or schwannomatosis should ignore this. These warning signs are still applicable, but these are particularly relevant for people with NF1 because the risk of a cancer is higher in those folks compared to NF2 or schwannomatosis. So if you notice that any one tumor is rapidly growing, that should immediately raise warning signs. That these tumors typically are stagnant. They're either not growing or they are growing very, very slowly over a period of years. If you notice appreciable difference in the size of any one tumor over the course of days, weeks, months, that should raise concern that might be a cancer. That needs prompt evaluation. Big tumors are also concerning. So tumors that are bigger than 5 centimeters, so 2.5 or 2 inches, that should at least raise a little bit of warning signs. You should have somebody look at that tumor if it's bigger than that size. Now, that doesn't guarantee that it is a malignancy. It just raises the suspicion. So those are the ones that need to be looked at a little bit closer. Now, these next two are what I would say are the really big warning signs. These are the ones that, you know, if I can leave any really sort of specific point of this talk, these next two are the take-home points of this talk. So spontaneous pain, and what I mean by that is pain even when the tumor is not being touched, and especially pain at night, here should be a major warning sign that this might not be a benign tumor. Pain that occurs when the tumor is touched, if you put a little tumor and that sends zingers down your arm or your leg, or that causes some pain kind of right around where you're touching, that's really common with benign tumors. That's not what I'm talking about. What I'm talking about is pain that is extremely severe, even when you're not touching it, and especially if that pain is happening at night. That's a warning sign. And then the next thing is neurologic deficits. And usually what I mean by that is weakness. Benign tumors usually do not cause weakness. Now, that doesn't mean 100% of the time weakness means cancer. It just means I need to really be concerned and get this evaluated. So if there is weakness, if there is severe pain, those things need to prompt a really quick and prompt evaluation to see, might this not be a benign nerve tumor anymore? So if any of those warning signs are present, that really means you need to get somebody who deals with nerve tumors to look at that tumor and evaluate it appropriately. So the reason why that is so important is that when we think about the management of a benign tumor versus a malignant tumor, they are completely different. Benign tumors, our goal is if we are going to take it out, and again, that's an if. We go back to those 3 points that I raised earlier in the talk. So symptomatic tumors, growing tumors, those are really the ones we're thinking about taking out. But the goal in taking those tumors out is to take the tumor out and leave the nerve working. That is not the same for malignancies. In a malignancy or a cancer, the goal is to completely remove the tumor. That means even with negative margins. So what I mean by that is usually that involves actually taking a rim of the normal tissue out with the tumor. And it usually means that the nerve that the tumor is in has to be sacrificed. You're going to lose the function of that nerve because our goal is to get absolutely all of the tumor out. Your best chance at having good cancer control comes from a complete resection at the time of surgery. So these are very, very different approaches and very, very different tumors. So how do we evaluate nerve tumors? Well, the clinical history is really important. This is where asking you questions about your tumor becomes so important. Do you have severe pain? Do you have weakness? Have you noticed that the tumor has been really quick growing? These are important things to try to tease out and for you to tell whoever is evaluating you. We then examine the tumor. Do we feel a tumor? Can we tell that this tumor feels different than it did, say, before? Is the tumor really hard and really firm? That might suggest a cancer. And then we switch modes and we evaluate these tumors by imaging them. So the most common two ways to image these kind of tumors are MRI or ultrasound. Now, specifically, if we are thinking about imaging tumors, we sometimes get we use a technique called PET imaging or PET scanning. This can give us some information about how likely these tumors are to be cancer. Without delving into some of the details of this, I will just leave it at saying it can be helpful, though it can sometimes be misleading. It is not 100% specific for a diagnosis of cancer. And then finally, our last thing in the armamentarium to evaluate these tumors is biopsy. But biopsy has its own set of problems. You can imagine in a big tumor, if we stick a needle into that tumor, we are sampling a very small part of that tumor. It's possible that over in a different section of the tumor, it's cancer, but right where they put the needle, it looks benign. So there is this phenomenon of sampling error. So again, even a biopsy is not perfectly predictive about this being a cancer or being a benign tumor, but we want to use this sparingly. If we think that a tumor is likely to be benign, those are not tumors we want to biopsy. And the reason for that is, if we ever want to go take it out later, the scarring that happens for a biopsy makes that tumor resection harder and more risky. We really want to reserve biopsy for those tumors that we think are likely to be cancer. Because if the biopsy shows that it is cancer, again, it completely changes our approach. We're going to go in and try to take that tumor out, usually even including sacrifice of the nerve. So it's really important that if a nerve tumor is being evaluated, that it's evaluated by somebody that has significant experience with these tumors. These tumors are difficult to remove, and so knowing the techniques and having some experience removing these tumors is really important. But also on the flip side, it's really important to have that surgeon be surrounded by a center that has a multidisciplinary sarcoma program. These cancerous versions of these tumors are what are called sarcomas. So having multiple types of physicians contributing to this evaluation, including a surgeon, a radiation doctor, an oncologist, if you're thinking that this might be a malignancy, it's really important to have multiple types of doctors thinking about this problem. That is how you will get the best treatment. And sometimes that includes surgery, sometimes that includes radiation, sometimes that includes chemotherapy. And knowing what the important sort of the components of that regimen should be means that you have to have a variety of doctors contributing to that plan. So I'll leave with a couple of things. This is just a little bit of a teaser. I'm a surgeon. I operate on these tumors, but very recently, even within the last month, there has been a new medical treatment approved This is approved now for pediatric patients that are 2 years or older with neurofibromatosis type 1, specifically for inoperable plexiform neurofibromas. This is essentially a chemotherapy. Now, I point this out to say that there are new developments all the time. And this is also why it's important to be at a center with some experience with these kind of tumors, so that they are aware and are abreast of the newest treatments that are coming out. It's certainly possible that someday these kind of things are going to put us surgeons out of business, that this is going to become a non-surgical problem. As it stands right now, most of these tumors are still best treated by surgery, but new things are coming out all the time. So what are we doing at Stanford? Well, we're doing a variety of things to try to push the limits of how we treat these tumors. We're developing artificial intelligence algorithms to try to improve our diagnosis so that we can better differentiate benign tumors and malignant tumors. We're trying to understand what the genetic drivers are of tumors that grow versus tumors that don't grow. Why do some tumors in the body grow while others stay stagnant? We don't know. We're trying to understand that. And then we're trying to use new imaging techniques to better identify which tumors are symptomatic. So this is an example of a new PET scanning technique that we're using to try to identify what tumors are painful. So you can see that this one tumor in this person lit up on this PET scan. The bright colors are the diagnostic feature. And it turned out that this tumor was very, very painful for this patient. And when we removed this tumor, the pain was significantly better. So this is a new thing that we're developing at Stanford, but other centers are developing their own new things. So it's just important to be kind of aware of what these new developments are. And I think that the future really involves continuing to develop better diagnosis and better treatment. What the next major advance will be predicting before it happens what tumors will go on to become cancer while they are still benign, and also being able to predict which tumors will ultimately grow and which tumors will not. This will let us treat these tumors earlier on with lower risk and try to prevent them from becoming cancers. And then I think ultimately, as I said, the non-surgical treatments are also being developed in parallel, and at some point in the future are very likely to make this a non-surgical disease. As it stands, most of the tumors are still surgical, but as these treatments come out, more and more of these tumors might be amenable to medical treatment rather than surgical treatment. So I hope that this has been a good kind of overview about thinking about these kind of tumors. Again, I'm very, very happy to answer questions about the presentation. I'm going to leave this information up for right now, including my email address and our website. And I think at this point, it might be best to see if anybody does have questions that I can answer for the last few minutes.
Dr. Wilson, thank you very much for an excellent presentation, and especially even the information about encouraging our family members to go to multidisciplinary clinics. And if anybody's on here and needs information about finding one across the country, you can reach out at admin@NF Network, and we'd be glad to help you find an NF clinic across the country. So I would like to give you the first question that came in tonight. This was from Lauren. She said, how do surgeons determine what type of tumor is present prior to surgery? Are MRIs good enough to determine if you're dealing with a schwannoma or a neurofibroma or a hybrid?
Yeah, so that is a very good question. And the short answer is the majority of time you actually can't reliably distinguish between the two. So in people who have a single tumor, you basically don't know. There's not a good way based on MRI to reliably distinguish between a schwannoma, neurofibroma, or a hybrid. Now, if people have a single tumor, meaning they don't have neurofibromatosis, they don't have schwannomatosis, the odds are that it is a schwannoma. Schwannomas are more common in non-genetic syndromes. In people with neurofibromatosis, again, it gets back at what type. In neurofibromatosis type 1, they are usually neurofibromas. In NF2, they are usually schwannomas. and in schwannomatosis, they are usually schwannomas. So you can go into it basically playing the odds based on what the disease process is, and that's how I counsel people about what the risks are. But the truth is, you sometimes get in there and you are fooled. That what you thought was likely to be a schwannoma is a neurofibroma, or vice versa. And again, at least at this point, we don't have good ways to try to tell the difference between the two. So that is one of the things that we are working on, using artificial intelligence algorithms to improve our diagnosis, not only of benign versus malignant, but also what the subtype of benign is. Again, schwannoma versus neurofibroma. So stay tuned in the future, but we don't have good ways to tell the difference right now.
Well, thank you. The next question is coming from Tina. She says, my daughter has both types of NF. Her tumors are all along the brainstem and spinal cord. She is declining in motor skills. Is this normal? And is there anything we can do to improve her outcome? She has gone through 2 major brain surgeries to remove tumors causing problems.
Yeah, so first of all, I'm just really sorry to hear this. One of the reasons why I, am very excited and very willing to talk to groups of people like this is I realize how tough of a disease this is. And we just really, really need better treatments over time. So again, first of all, I'm sorry to hear that. But second, so you have to sort of pick your battles. Again, you can't take all the tumors out. That's just not realistic. And so this becomes sort of a stepwise approach to picking the tumors that are most symptomatic. So which tumors are compressing the brainstem, which tumors are compressing the spinal cord, and trying to remove those if possible, or at least trying to remove enough of the tumor that it relieves the compression on the spinal cord or brainstem. Now, so that is certainly the surgical approach to that. But this is also where it becomes very important to be at a center that has a multidisciplinary approach to this. There are some chemotherapy agents that can be considered for people that have multiple large tumors. And in particular, with this newly approved agent for people with NF1, your daughter might actually be a candidate for use of this new agent. So I would say that if you are not already part of a multidisciplinary center where there are oncologists that are part of the care, radiation oncologists that are part of the care, and surgeons, my biggest recommendation would be that to switch your care to somewhere that has a multidisciplinary treatment team. So that you can be able to consider both surgical options and medical options.
There's a lot of questions here, Dr. Wilson, and really good ones too. I'm going through them, but this one here comes from Beth. Is selumetinib available to adult patients with tumors in the nerve sheath along the spinal cord?
So right now, as it is approved for pediatric patients. So I don't want to get into off-label uses of medications, but in an adult, that would be considered an off-label use. That would not be the FDA-approved indication. That being said, that is something that you could talk to an oncologist about. That would be, again, I'd have to emphasize that is a potential off-label use. That is not what the drug is approved for. So if you follow the guidelines and the approved indication, that would not fit it. That being said, it's an approved medication, and you can always talk to your oncologist about whether that would be appropriate.
Okay, here's one from Robert. The risk shown was the study average for a given case. How accurately can a surgeon assess the risk profile for a tumor resection?
Yeah, so I think that all of these studies, both the study that I showed that is not from my group, as well as the aggregated data that we have not published yet, gives you a general sense of what the risk is, sort of for all comers. I think that the advantage of going to a surgeon who has a lot of experience with these kind of tumors is that they can then take what is sort of a background of what the risk profile looks like for all nerve tumors and try to tailor it to your specific tumor. Do I think the risk might be lower than that average based on the size and the location and the nerve involved? Do I think it might be higher based on those things? At the end of the day, you can quote these studies, which are sort of the average risk profile. For any one tumor, you're not going to be able to say, well, your chance is, say, 40% versus the person next to you, which is 10%. But I think that a surgeon with experience ought to be able to give you a sense of how does your specific risk compare to the average risk? Is it higher, lower, or about the same? That's about the best we can do. But I think that does usually give people enough information that they can make an informed decision about whether they would want to go ahead with the tumor removal.
Thank you. And here's another one. I'm wanting to know if the schwannoma described would apply to vestibular schwannomas. That's from Barbara.
Yeah. So the general principles of vestibular schwannomas, as far as how they grow, what the tumor type really is, everything that I talked about today is applicable to that kind of tumor at a physiologic level. The surgery for a vestibular schwannoma, though, or the treatment approach is slightly different. That could be a whole talk in and of itself. Whereas tumors that are in the extremities, we are usually trying to take the tumor out and leave the nerve behind and working. That is usually not the approach for vestibular schwannomas. It's just not possible because of the access that we have. So the nerve that tumor grows on is usually lost as part of the operation. What you are trying to spare, if possible, is the hearing nerve, which is right next door, and the nerve that supplies the movement of the face, which is also right next door. Those nerves are all in very close proximity. So the goal of the surgery is usually to get the tumor out and spare face function and hearing if possible. Now, in addition to that, though, there is an even more nuanced discussion about when should you do surgery, what the approach of surgery should be, and when you might consider radiation as a treatment, which is a much more common treatment for vestibular schwannomas than it is for benign tumors other places in the body. So I'll sort of give the short answer, which is to say, in some ways, you might disregard what I said specifically for vestibular schwannomas, which could be a whole discussion in and of itself, even though the fundamentals of that tumor are the same as what I talked about.
Well, thank you. This one is from Karen. She said, what is the difference between a tumor that shows that is soft and one that is hard?
Yeah, so that's, again, that's a little bit of a gradient. But really firm tumors, I mean, a tumor that you touch and it feels like it is a rock, that is worrisome. Cancers tend to be much firmer, much more rigid tumors, whereas benign tumors tend to be softer. They're still firm, but they feel rubbery. So if I was going to give an analogy for a benign versus a malignant tumor, a benign tumor typically feels firm, rubbery, whereas a malignant tumor oftentimes feels hard, like a rock. So again, that's not 100% guaranteed. But if you have a tumor that is very, very firm, feels like a rock, that just raises the suspicion, and I would say should prompt you to get that tumor evaluated more urgently.
Okay, thank you. What's your opinion of removal of neurofibroma by electrodesiccation? It's from Therese.
Yeah, so that's that's not a technique that I typically do. And honestly, I have not seen a lot of literature about that technique. I know that there are people that talk about using that technique. And there are a variety of other techniques that people have used, a variety of different kind of lasers that people have used to remove these tumors. I think we are a little bit too naive from a data standpoint to really be able to give a recommendation for or against that. What I guess I would say is that that's a discussion for probably to be had with the surgeon who's proposing that, to understand how many of them they have done with that technique, what their outcomes have been, and what they see as the advantages of using that technique over what would be, I guess what I would say is a more standard technique, which is what I described here today.
Thank you. This comes from Dale. He said, I have schwannomatosis. The source of nerve pain can be elusive. What can be done to narrow down the source of pain so that any MRI may find the source or schwannoma? I do understand that some pain from schwannomatosis may be secreted from a tumor from some research. What are your thoughts on this topic?
Yeah, so a couple of good sort of points there, which is that you really have to think about the pain as almost being subdivided into kind of two general classes. I do think that people with schwannomatosis and potentially other forms of neurofibromatosis can get a generalized pain syndrome. And I think we are only starting to understand that. And I think that that is likely from secreted factors or a variety of things that are related to having these tumors. But that is different than the pain that people can get, or I think more commonly get, in a very specific distribution. So usually what people will describe is that they have pain in their right arm that seems to start around the elbow and shoot down to the fingers, for example. And I notice that if I touch around the elbow, that seems to make the pain worse. That is the kind of pain that then can be narrowed down to a single nerve. Now, the problem is that with people with schwannomatosis or neurofibromatosis, that single nerve can sometimes have multiple tumors. And then the question is, well, which of those tumors is really causing the problem? So if it's a tumor that can be touched, oftentimes the best predictor is touching each of the individual tumors and seeing which one reproduces the pain. The one that you touch and that reproduces the pain, that's usually the one to go after. In the absence of that, though, our MRI techniques that we have right now do not reliably differentiate between which tumors are causing problems and which are not. You might hypothesize that if one tumor is growing and the pain is increasing, that the growing tumor might be the one causing the pain, but it is not always. So that's why, one of the things that we are doing here at Stanford is trying to use this new PET imaging technique really as a way to identify pain-generating tumors. That is really specifically what we are trying to do. Right now, that is still under a research protocol that is only available here at Stanford. I think that we will eventually be able to broaden that and make that commonly available, but right now it's still a research technique. So if that were something that you were interested in, we could enroll you in the study here at Stanford and image your tumors and see if we can identify which one is the pain-generating tumor. In the absence of doing that, though, we're left with the more standard techniques, which is try to identify which tumors are growing, try to palpate the tumors and see if we can identify which one is painful. And otherwise, we're sometimes left with kind of our best guess as to which tumor it might be. And that's difficult. That's a hard place to be in because we're not always correct about that.
Thank you. I'm going to try to put a couple of questions here in one because they're similar. They're looking for what type of doctor should they see? What disciplines need to be included in a multidisciplinary team for NF? Yeah, I think that's it for right now. If you could describe that, that would be appreciated. Thank you.
Yeah. So in my opinion, a multidisciplinary team typically would involve, I'm going to sort of give at least what the baseline group should consist of, and then probably what the ideal group should consist of. So the baseline group should consist of an oncologist who would consider themselves to be a sarcoma specialist and or a neuro-oncology physician. So those are both sort of subspecialists within oncology. So a medical oncologist, though, is a very important part of the team. The second type of physician would be a radiation oncologist. Those are the doctors that really specialize in delivering radiation treatment. And then the third kind of doctor would be a surgeon. And the surgeons that oftentimes are on these teams are kind of a variety, actually. Sometimes they are orthopedic surgeons. Sometimes they are neurosurgeons, which is what my training is. But fundamentally, they should consider themselves to be a nerve surgeon. And again, that can come from multiple specialties: neurosurgery, orthopedic surgery, and sometimes plastic surgery as well. So a nerve surgeon, an oncologist, and a radiation oncologist is what I would say is sort of the foundation of the team. And then in addition, sometimes as part of these teams, there also might be a neurologist, and then there may be a geneticist, and that could come as either a medical geneticist or a neurogeneticist, but somebody that kind of specializes in the genetics of these syndromes, genetic counseling, and monitoring for things that actually are not even necessarily just the tumors. There are a variety of other things that crop up as a result of genetic syndromes that are important to monitor for. So that's, I guess, how I would describe the multidisciplinary team.
Thank you. And in order to try to get these questions answered for everybody, I'm going to combine some again this time. So this is all about selumetinib, the new drug that's out. They're looking for your experience with that. One family is asking, if you have a plexiform neurofibroma, can you ask any doctor to write a prescription? Another family is saying, would you recommend their child take it even if they aren't experiencing any pain? And then if you have neurofibromas, can you take this for the reduction of neurofibromas and not just plexiforms?
Yeah, so I'm going to lead off by saying probably what is the most important part of this answer. I have no experience with this drug. It is brand new to be approved. I mean, literally within the last, I think, 2 or 3 weeks, this drug was approved. So we here at Stanford are now sort of trying to figure out where this goes in our algorithm for treatment. And I don't think we have that figured out yet. And I would venture to guess most centers don't have that figured out yet. So I think that's maybe my easy way out of some of those questions. But that is to say that I don't know the answers. I don't think we have enough experience yet, and certainly I don't have enough experience yet to know when you should be using that drug and when you shouldn't. But I think I could, probably pretty reliably say if you have a tumor that is plexiform, not causing symptoms and not growing rapidly, that probably still should not be treated. This really should be reserved for either symptomatic plexiform neurofibromas or plexiform neurofibromas that are growing, at least, I would say, before treatment. But I think, again, even that is going to be debatable. In response to the question about can you see any doctor to have that written, I don't think that would be appropriate. I think that this really should be directed by an oncologist. They would be the people that would write for this medication and direct its treatment.
Thank you. I'm going to try to just maybe get 2 more out of you, but there's a lot of questions in here. One of them was a basic question. I don't want to keep you all night. We really do appreciate your giving up your time like this for us to see. This one here, I'd like to do this one, and then I'm going to pick through one more after this one. Someone is asking, can a benign tumor turn cancerous?
Yes. So this gets after why malignancies are more common in neurofibromatosis type 1 than they are in NF2 or schwannomatosis. And the reason for that is neurofibromas have a higher risk of turning into a malignancy compared to schwannomas. the risk of a schwannoma turning into a malignancy is quite low. It's not zero, but it's quite low. The risk of a neurofibroma turning into a malignancy is higher. And specifically, plexiform neurofibromas that are deeper, meaning that not the ones that are out in the skin, those seem to be the ones that have the highest risk of turning into a cancer. So in people with neurofibromatosis, it's actually, we think, probably pretty rare for a tumor to start out as a malignancy. Much more common for somebody to have a benign neurofibroma that then turns into a malignancy. And unfortunately, in neurofibromatosis type 1, the lifetime risk of having a cancer is about 10%. And that probably just has to do with the fact that most people with NF1 have a lot of tumors, which means that they have a lot of possible chances of any one of those turning into a cancer. So that is why I would say that you really have to be on the lookout for those warning signs. Any individual tumor that is rapidly growing, a tumor that is now newly causing a lot of pain, a tumor that is now causing weakness, all of those things need to raise concern that what was once a benign tumor now might be a cancer, and that needs really urgent evaluation.
Thank you very much. I'm really having a hard time choosing the last one, but I think I'm going to go with something that keeps coming up here. So they're looking for additional information on selumetinib. Do you know, we know that the FDA-approved drug is from AstraZeneca. Can you recommend a place for them to go to get additional information on the drug?
Yeah, that's a good question. I mean, there just are not so the truth is I don't know. The place where you might start for basic information might be on the AstraZeneca website. They are going to have, sort of their summary of the drug published. There would certainly be, a few academic articles that if you just searched in the PubMed database, which is the kind of academic database that's supported by the government. If you search for selumetinib, there will be some articles that will come up. But I really think at least at this point where we are pretty limited with our information, probably your best sort of go-to resource would be hopefully you're already seeing a multidisciplinary team and going to the oncologist that is part of that team and discussing this drug and where it might be used and what the indications are and the risks would probably be your best bet. I think the oncologist that is part of your multidisciplinary team, at least for now, is your best resource.
Well, thank you very much, Dr. Wilson. It's been an amazing evening. We've learned so much from you tonight. We truly, truly appreciate your time. And for the people who are attending, you will get a link to this webinar. You'll be able to see that shortly. It'll also be posted on the NF Network website. So the network would like to thank you and thank our generous donors for making the webinar possible. Improving the quality of life for our individuals with NF through education is a major goal for the NF Network. And then we would like to thank Dr. Wilson and everyone for attending and say good evening. Thank you and have a nice night.
Thank you all.
Bye-bye.
Bye-bye.